Palliative care is a new and rapidly growing field in the field of medicine, and I wanted to do this video to not only explain to you guys what is palliative care, but actually talk to you guys about what we actually do, because not only do patients misunderstand what we do, but also the doctors as well. What's going on, you guys? My name is Dr. Tochi Waneri-Wosu. I'm currently a hospice and palliative care fellow here in California, and I wanted to do this video to not only clarify some of the things that palliative care actually does, but to give you guys a little bit of a roadmap of what to think when palliative care gets introduced in your care or a loved one's care. When I actually meet patients for the first time as a palliative care physician, I first do a little bit of an introductory statement that's pretty vague, but what I say is palliative care is a team here in the hospital of support members that get involved whenever someone has a very serious illness. A lot of times I'll do my interview with them and touch up a lot of different things so they kind of get a feeling and understanding of what we do. But for you guys, what I'm going to do is actually break down exactly every single category that we cover whenever we see our patients. That way you have a better understanding of what we do. Now, the four different categories that we cover is goals of care, symptom management, transitions of care, and interdisciplinary care. Now, in the goals of care section, goals of care, a lot of times people will hear this phrase in the hospital or even put it in their notes and documentation. But basically, it's a very vague phrase that essentially means it is what is this patient's goals and wishes, and how do we pair that with what's going on with them medically and come up with a plan that is very specific to them, that is aligning with what's okay with them. This isn't a one-size-fits-all approach. Every single patient has their own different personalities, what they value and what they want as they get sicker and sicker. So a lot of times what we do in this category is we have a lot of meetings with them. We have a lot of family meetings. And what we do in those family meetings is elucidate, who is this person? What do they value? How do they see the end of their life going? And based off of all of that, what are their goals, hopes, wishes, worries? How do we actually determine what's the best route in terms for them to move forward with? Are they okay being a full code, meaning that if their heart would have stopped and they would have died? Are they okay getting chest compressions, being on a ventilator, possibly being in a nursing home for a long time after the fact if that code doesn't go too well? Do they want to be a DNR, DNI, meaning that they don't want CPR, they don't want intubation, they don't want life support? Those are a lot of the things that we figure out. And a lot of times, the thing that I like to do is I like to break this up into three different categories. Do you want the most aggressive approach to your care? Do you want a least aggressive approach? Or do you want a little bit more of that middle ground where you're okay with some certain interventions, but you're not okay with a lot of other interventions? And that is a lot of the times where we get involved, also with the specialists from other teams, such as cardiologists, gastroenterologists, the ICU teams, and we try to figure out what are they okay with, what are they not okay with, what is feasible, what is being offered, and how we actually come up with a plan to determine how their care goes forward. That is something that can change over time. As you get sicker and sicker, you may not be okay with a lot of the most aggressive approaches later on. And if you're getting better, you might be okay getting some of those more aggressive approaches. And it's something that is on a continuum and may be fluctuating throughout your medical course. But a lot of times when our team, the palliative care team, is getting involved and someone is continuously declining, we try to talk with our patients to determine, okay, what are you okay with? And this is what the likely trajectory is of your illness. So are you really okay with getting some of these aggressive care approaches moving on later in your life? A lot of other things that we do in this section as well is conflict management. So a lot of times in our patients' care, it's not only them, they have their family members, they have children, they have spouses, they have siblings. And a lot of times when our patient can't advocate for themselves, we oftentimes have to get involved and help mediate between family members who have never really had this discussion with their loved one, but they each have differing feelings on what they think that their loved one may have wanted at the end of life. And a lot of times we have to have a lot of meetings. It's not like a one and done approach. Sometimes it may be 2, 3, 4, 5 meetings to try to figure out what is in this patient's best interest, not what a loved one thinks that they would have wanted, but what they think that their loved one may have wanted for themselves. The next section that we deal with is symptom management. And as you get sicker and sicker with a lot of these very serious chronic illnesses, you have a lot of symptoms that you develop, whether it's pain, shortness of breath, nausea and vomiting, constipation, and even with the treatments that we impose on people to try to help with their serious illnesses, those also have side effects as well. So we have to help manage those symptoms as well. A good example is someone that has end stage cancer that has bone pain, that we treat them with steroids and opioids with. A lot of times with the opioids, you can become nauseous, you can become constipated. So what we have to do is use other medications to try to mitigate the symptoms that you may be feeling from the treatments that we're using for your cancer symptoms. So a lot of times we have to figure out what are the best approaches. A lot of times because they're very sick and they're getting older, we have to be very fine-tuned in how we manage these symptoms. So we have to be very good with managing opioids, managing pain, shortness of breath, nausea, vomiting, constipation, and basically anything that comes from these very serious illnesses. So that's another thing that we do to help a lot with as well. The next section that we deal with is transitions of care. And in this section, I remember when I started off my fellowship, I was a little confused about what this actual side of palliative care actually covers. But the main thing that we actually determined that this covers is one, prognostication. And this is something that is very difficult and is a very developing field in medicine. And a lot of times, and a lot of papers have gone over this, doctors that aren't in palliative care or just doctors in general, they tend to be very, very bad at prognosticating. And a lot of times this is something that patients and families want to know is how much time do I have left? And this is a very hard question to ask because everybody is different. And especially with the age of medicine that we are in now, we have a lot of new developing strategies that have pushed people to live a lot longer than they would have been maybe like 10, 15, 20 years ago. A lot of times what we do in this section in prognostication is going based off of function. There's a lot of different scores out there known as like the Palliative Performance Scale, the ECOG for cancer patient, and each serious illnesses such as heart failure, COPD. A lot of these illnesses have their own prognostication scores. And one of the biggest things that we have to really look at is function. And when I mean function is how strong are you? How mobile are you? Are you just in bed all the time? Are you actually able to do some of your activities of daily living? So are you able to care for yourself, go to the bathroom on your own? These are a lot of things that we're looking at. And the less and less that you're able to do with your ADLs, which is short for the activities of daily living, the less and less that you're able to do on your own, the more that's more of a sign that, okay, you are starting to decline a lot. And the more and more that you decline, the harder it is that for your body to keep up with that and fight against this illness. So a lot of times this is something that we're looking at, and whenever we're prognosticating a patient, we not only look at how you are now, but how your trajectory has been over the last couple of months, years, and looking at where you are now in comparison to the past. Because if you are declining pretty quickly, like say you were pretty functional maybe like a month or two ago, but now like you're significantly declined, then you're going to keep on declining at that same rate. However, if you are a patient, say with like dementia, and you've been declining very, very slowly, usually your decline is going to stay on that same trajectory unless you take like super big hits from like infections or anything else that hits your health significantly. The next thing that we look at in this section is advanced care planning. Now, what's included in advanced care planning? The biggest things that we look at is advanced directives. Now, advanced directives, they cover a lot, and a lot of times they're not super helpful in terms of some of the things that they ask for in there. But the most important thing that we look for in there are durable power of attorneys of health. So have you designated someone to make decisions for you if you're not able to advocate for yourself? Usually we have like a first and a second line person. Sometimes it's a spouse, sometimes it's a child, sometimes it's a friend, but this is a legal person that you designate. And a lot of times when you have a designated decision maker, we look at it if it's a legal decision maker or a non-legal verbal decision maker. And a lot of times the advanced directives, this is a legal person. So you have to get a notary, you have to get a lawyer, you have to like fill it out. So it's very specific, and no matter who gets involved, this person that's your designated durable power of attorney of health, we always have to go to that person to help make decisions, and we can't go to someone else superseding them because this person has legally designated someone to make decisions for them. The other things that we also see in those advanced directives are living wills. We also have a financial power of attorney. But for a medical side, we are mostly looking at that durable power of attorney of health. And then sometimes people put their medical wishes in terms of like life support, if they're okay with like every single intervention. But the thing that I've noticed with these advanced directives, it's good to get an idea what they wanted at that time, but a lot of times people aren't just updating their advanced directives every like year, 2 years, 3 years. Sometimes people do advanced directives from like 5, 10 years ago and they don't update them. But your mindset from maybe when you're like 30s as opposed to when you're 50s, you're gonna feel a lot different in terms of what you would want for yourself. And a lot of times it's a good jumping board to start the conversation. Like, hey, I saw you put in your advanced directives that you would have wanted this, this, and that in terms of your end of life wishes. Is that still the case? So we're not just looking at your advanced directives and saying, okay, they wanted this when they're like 30 and they're 70 now. It's nice to have that conversation later on. Now, the thing that is more helpful are people's physician orders of life-sustaining treatments. At my state, it's called a pulse, and other states, I believe they have different names for these. But if you guys have seen this before, it's a big pink paper, and on there, it says what we should do if your heart were to stop and you would have died. Now, on this paper, there's a couple of different options that you can choose, but it's broken up into the first section, a second section, and then a third section. The first section is where you put if you want to be a full code or a DNR. The full code means if your heart were to stop, we do every single thing. We do chest compressions, we can intubate you if we needed, meaning that we can put a tube down your throat to help you breathe and connect you to a breathing machine. The second section is elucidating a little bit more in the DNR section. So are you a DNR full treatment, meaning that you're okay to be intubated and doing every single other treatments? Are you a DNR selective, meaning that you are not okay being intubated, but you're still okay having every single other treatments like antibiotics, pressors. You can have like BiPAP, CPAP, which are just breathing apparatuses. Or are you a DNR comfort, meaning that you just want things to keep you comfortable, and if your heart were to stop, you don't want CPR or intubation. A lot of people that are in the hospice section get transitioned to the DNR comfort section, and this essentially is just to kind of make sure that they don't get brought to the hospital unnecessarily because they're more in that comfort stage. A lot of times people want to either die at home or stay at home, and they don't want to go through the rigmarole of all the pokes and prods and medications and interventions that you would get when you go to the hospital. And then the last section, which is a section I notice people don't really fill out that much, is the artificial nutrition section. So are you okay with having like an NG tube or a PEG tube and getting fed through like artificial nutrition, which is basically just like liquid nutrition to kind of help you meet your requirements. And then the last section that we cover is interdisciplinary care. Now, with palliative care, one of the main things that I mentioned before is that we are a group here in the hospital. So it's not just doctors, we also have nurses, nurse practitioners, we have PAs, we have social workers, we have chaplains, we have a lot of different other team members, pharmacists, music therapists, psych people. So it's a lot of different team members. And in this team members section with the interdisciplinary care, we like to make sure that we cover our patients from a comprehensive approach. So are we covering their spiritual needs, their financial needs? Are we covering some of their psychosocial needs? And a lot of things that you'll notice is that when you have someone with very serious illnesses, it's not just their physical body that's affected, it's their mental, their psychological capabilities that are affected, their finances are affected a lot. So a lot of times we'll have social workers going in there and meet them. We'll have chaplains going in there and meeting them. We'll have like a therapist going in there and meeting them. And we try to cover the patients from a comprehensive approach because you're not just your physical body, you are a complete person as well. So we want to make sure that we cover people in the comprehensive approach and make sure that we're addressing all of their needs. So an example of this is you have a patient, they have end-stage cancer, they're getting chemo, and one of the main things that they notice is that they're having difficulty making payments for the chemotherapy because a lot of these things are very expensive. So what we can do is having a social worker going in there, making sure that they screen them for insurance issues. They can see if they can try to find some sort of like supportive groups to help them pay for their finances. Doctors aren't really trained in these side of things. And because palliative care is a comprehensive approach, you really have to rely on your other team members to kind of help you screen for these things because you don't really know what you don't know. So these specialists are able to go meet your patients and ask them the questions and things that they're trained in and help you address things that are really affecting the patient, but people don't really feel comfortable bringing up with their doctors because they don't feel like they can help them from that perspective. Now, the last thing that I want to cover is how is this all different from hospice? Now, hospice is actually the originator of all this. Palliative care is something that developed from hospice, and hospice essentially means you have a patient with a very serious illness and we think that the prognosis, which is the amount of time that we think that they have left, is 6 months or less. And in that time, there is a couple of things that you have to determine. One, do they qualify for hospice? Is like, do we actually think this person only has 6 months or less to live? Two, are they gonna benefit from hospice? Because yes, you can qualify from it, but are you actually gonna benefit from their service? The last thing is, do they accept to be in hospice? You can't just put someone on hospice or tell someone like, okay, you're going to be on hospice. No, you have to qualify for it. You have to benefit from it, and you have to actually be okay with it. So you have to actually give your verbal and written consent to be on hospice. This is all different from palliative care because you can get palliative care at any sort of time in your illness trajectory whenever you have a serious illness. But hospice is specifically is, okay, we only think you have 6 months or less, and we want to prioritize comfort, and you want to prioritize comfort. Palliative care is not just comfort, it's trying to manage everything that comes with your disease, whether it's physical, psychological, social, spiritual. We want to address all those needs as you're going through it. And a lot of times we follow people longitudinally as palliative care physicians. And when we hit that point of like, okay, I think we've done everything we can do to kind of help you in the stage, and you're starting to reach the end point of your disease, do you want to prioritize comfort? And if it's yes, okay, let's talk about hospice. And a lot of times people are fearful of the word hospice, but essentially we're just saying, hey, we want to just make sure that we keep you comfortable in this time. And we don't think that all these other interventions are going to help you. And we want to make sure that you are comfortable in this stage as you allow for this natural process of death to come by. So I like to tell patients and family members that people are not just being abandoned and thrown into some like facility for hospice to just wait for them to die. We actually taking care of them and making sure that they have a peaceful death. So that is essentially what palliative care is and what we do as palliative care team members. If you guys have questions about anything that I said in this video, put in the comment section down below. Drop a like in this video if you also enjoyed this video. I'm also going to drop a video on hospice specifically and how that actually works, what they actually do, and how it actually works in the background. So if you guys are interested in a hospice video, put it in the comment section down below. And if you guys are interested, check out this last video that I did on this channel if you guys are interested on more palliative care topics. So I'll see you guys later. Peace. Have a nice day.